Assalamu alaikum, the long clinical consultation day. First scenario, or the only scenario today, Mr. Sami, 65 years old, with a complaint of dizziness. Please take history, examine the patient, address his concerns. So you can start, Dr. Ahmed. Here you go.
Hello, I am Dr. Mansour, one of the exam candidate. I'm asked to take history and address your concern after end of examination. Is it all right with you?
Yes, doctor. I am Muhammad, son of Mr. Sami.
Nice to meet you, Mr. Sam. Can I confirm
Okay.
your age, please?
Yes, my age is 35, but my father 65.
Okay. Mr. Muhammad, do you know anything about your father?
Yes, doctor. My father complaining of these spells. It happened many times, so I came to the hospital to know what is the cause.
Okay, you say that's happened many times.
Yes, doctor.
When was the last time?
Last time today, doctor.
Today.
Yes.
And before, when was it started?
Yes, it happened many times. I think since 2 months. It happened, I think, 6 or 7 times.
6 or 7 times.
Yes,
Is
doctor.
there any special frequency happened in week many times and after that rest? Or
No, doctor. I think it happened one time, once per week. I think like that.
okay, do you live with him? Have you witnessed them?
Sometimes I visit my father.
Mhm.
Mhm.
And can you describe what has happened when he feeling dizziness? But what has done before?
Yes,
But
it happened like doctor when he was walking, when he was sitting. Um,
while sitting, also have dizziness.
yes, doctor. When he was standing, also he have these spells. Yes.
It's most while standing or no rule for standing or sitting.
I think, doctor, it happened during standing, during walking.
Mhm.
Anytime it happened.
Is he steady while walking?
Yes, doctor, it happened also one time when he was walking.
Is he steady by walking?
So, sorry, unsteady?
Yes.
No, doctor, no. It is
Okay.
normal. Mhm.
Okay. Any shaking of the hands?
No,
Does he lose his consciousness
no, doctor, never lose his
or
consciousness.
fall down?
No, doctor, he never fall down.
Okay. Any headache?
Headache, no.
No. Any blurring of vision?
Blurring of vision, yes, doctor, sometimes.
Okay. Dumping on object while walking?
No, doctor, no.
Okay. Any weakness?
Weakness?
Mhm.
No, doctor, no.
Any numbness?
Yes, doctor, he told me many times he has numbness. Yes.
In her arm or legs or both of them?
Both, doctor, the arm and the leg.
Mhm. Okay. Does he have awareness of heartbeat?
Sometimes, doctor, yes, you are right. He has awareness of, yes, he has racing heart.
Do you know of that regular like that? Or
I don't know, doctor. I don't
okay.
know.
And that happened to the time of this feeling of dizziness?
Yes, doctor, it happened during business. He felt racing heart.
Mm-hmm.
Yes.
Okay. Any shortness of breath?
Short suppress, no.
Okay. Any chest pain?
No, doctor. Chest pain, no.
Any high body temperature?
No, never.
Any sweating?
Sweating, no.
Any weight loss or weight gain?
Yes, doctor. I think his clothes become loose than before.
Mm-hmm.
So I think he lose some weight.
How many kilo over how much?
I
Over
think, yes, doctor. I think 5 kg per 3 months.
Did he seek medical advice in this regard?
No, doctor, no, because he lived alone. He lived alone. So I work outside the country. So I don't think he go
And
don't seek medical advice. Yes.
and his loose stool, is there any blood and how often?
I don't know, doctor.
Okay. Any joint pain or back pain?
No.
Any tummy pain or tummy distension?
Tummy pain or tummy distension? Not pain, doctor, but he told me many times he has discomfort in his tummy.
Discomfort is related to meat or?
I think yes, doctor. It is maybe related to meal or not. I don't know. But he told me many times he had discomfort in his tummy.
Okay. Any problem with water work regarding
Like
amount, volume, or color, or frothy?
yes, I think doctor his water work become frothy nowadays.
Any leg swelling?
No,
Any change in the color of the skin?
no.
Okay. Does he has any long-standing disease?
Yes, doctor. He has high blood sugar. He
Mhm.
take insulin for that. I think since 20 years, and he has high blood pressure. He take enalapril 5 milligram, and he take apixaban 5 milligram, and statin for high fats.
Why he take apixaban?
I don't know, doctor. I think he takes this medication since 3 years. He came to the hospital, and the doctor prescribed him apixaban.
Okay, but he doesn't suffer from heart attacks before or something like that.
Never, doctor.
Okay. And what's about his blood sugar? What is the last reading of hemoglobin A1C? This long time blood
His accumulated blood sugar, I think last time it was 8.5
8.5 in insulin.
on insulin. Yes, he take insulin.
Another question, does he suffered from any heart attack before or stroke or mini stroke?
No, doctor, no.
Okay. Does he has any kidney problems? None.
Like what, doctor? I don't know.
In routine investigation has tested his kidney function.
No, doctor, no. I think no.
Okay.
Mhm.
And what's about his diet?
He tried to be in balanced diet, but he couldn't. He can't eat much, doctor, nowadays.
Mhm. So has no appetite.
I think his appetite nowadays is not good. Yes, doctor.
Okay. Any difficulty with swallowing?
No.
Okay. Thank you. Any history of operation before surgical intervention or hospital admission or trauma?
Yes, doctor. I think he admitted last month. I
Mm-hmm.
think that because of low blood sugar.
Mm-hmm.
One time only.
Was admitted to intensive care units?
Yes, doctor. He came to the emergency unit, and the doctors there told me that he has low blood sugar. So he gave my father some fluid and discharged it.
Okay. Regarding loose stool, do you know if he is just alternating with hard stool,
No, doctor, but yes, sometimes he had loose stool. Yes.
but not in change with hard stool?
No, doctor, no, no,
Okay, on doesn't awake him from sleep.
no, doctor.
Okay,
Awake him from sleep? No, doctor, no.
okay. Can I examine you?
Yes, doctor, please.
Okay. I will start with the hand.
Okay.
In colinekia, palmar erythema, sweating.
No. Did you want any other thing? It's the hand?
Any resting tremor or flapping tremor?
No.
Any debutering contracture?
No.
Okay. I will examine blood pressure by
Yes.
sitting and standing.
Yes, there is difference between sitting and standing blood pressure. The difference over 20.
Okay, thank you.
Mhm.
Do you feel any pain in your arm now, Mr. Sim?
Pain, no, doctor. No.
Okay. I will check for proximal myopathy.
Okay, no proximal myopathy.
Okay, I will go for the head. I will see the neck veins.
Okay,
in
no,
collapse.
no. Yes, no, doctor. No, no
Okay, I will.
GVP. Increase GVP. Okay.
I will see the eye in a pallor in jaundice.
No, pallor, no jaundice.
Okay, I will see for the mouth of any dryness of the tongue, any hyperpigmentation, telangiectasia.
No, no, doctor. Nothing.
Okay, thank you. I will examine the heart.
Yes. Okay.
Okay.
What you want from the heart?
Apical pulsation, apex of the heart.
Yes, there is irregular heartbeats.
Thank you.
Sorry, irregular. Okay.
Irregular, thank you.
Mhm.
I will examine for any heart sound and any additional murmurs.
No murmur.
Okay. I will auscultate for carotid.
Carotid. Okay. No bruit.
Okay. I will auscultate the back of the chest.
The back of the chest. Yes. Okay. It is. There is an inspiratory crepitation, fine basal crepitation, in the back of the chest.
Thank you.
Mhm.
I will go for the abdomen, do both superficial palpation. Do you have any pain in your tummy now?
No, doctor. No.
Okay. I will palpate for tenderness and
Yes.
any
Okay.
organomegaly.
Okay. No organomegaly, doctor.
Okay. I will see the kidney.
Okay. It is
Mm.
no ballottoment kidney.
Mm. Thank you. I will go for legs. I see in
Okay.
lower lymphedema.
No lower lymphedema.
Okay.
Anything other than lower lymphedema?
Any skin rash or diabetic food or atrophic changes?
Yes. Okay. No.
No. Okay. Thank you.
Mhm.
I want to examine. Can you stand up?
Yes. Okay. I now stand up.
Okay. I will ask the patient with safety if Romberg signs.
Yes. Okay. I will close now my eyes.
Mhm.
There is positive Romberg signs.
Okay. Do you feel unsteady now? You can sit down. Okay.
Yes. I can. Yes. I will sit down.
Do you have any concern, Mr. Sen?
2 minutes.
Yes, doctor. What my father have?
Yes, your father is suffering from the long-standing complication of high blood sugar, which called autonomic neuropathy, and that's responsible for his complaining with low blood pressure while standing, and also the nerve cable was involved as complication of his high blood sugar, causing numbing in his hand and unsteadiness.
Okay. It is serious condition, doctor.
It's not serious condition if not treated. We should control his blood sugar. That's the first thing, and do some investigations for him. Firstly, I want to check his blood sugar now and do some investigation to be assured there is no other problem, because he has problem with water work, frost urine, maybe the kidney also involved. Do you have any other concern?
Yes, doctor. Any advice for this disease pills?
Yes, I will refer you to group of doctor, including gland doctor and internal specialized nurse, to revise with him how to take insulin, and he should take plenty of fluids to replace what we have lost. And I will do another meeting and inform you with the update. I have one question. With whom are your father living?
He live alone, doctor.
Okay. I can call the social worker to ensure that's okay. What are he doing for a living?
Yes, doctor. He is retired now.
Okay.
Mm.
How does impact his daily life?
Yes, doctor.
Time is up.
Okay,
Yes,
doctor.
time is up.
Okay, please, okay, Dr. Ahmed, please present your case and tell me the positive signs in this patient.
Okay, this gentleman complaining of dyspnea with orthostatic hypotension as evidence of while standing with significant blood pressure drop. He has long-standing diabetes on insulin with not or incorrectly control with many complications of diabetes, peripheral neuropathy with involvement of his legs, and also autonomic neuropathy as evidenced by loose stool.
Okay,
And
did you check the peripheral neuropathy? The patient has peripheral neuropathy.
I have tested only for Romberg sign.
Okay, okay.
He has also functional diarrhea maybe, and also diabetic nephropathy in the form of
What is the cause of diarrhea in this patient?
functional autonomic neuropathy.
Okay, any other? Any
He-
other patient diagnosis for this diarrhea?
this may be due to bacterial overgrowth.
Okay.
Okay, and in this age should be considered also susceptibility of cancer, colon cancer, according to age, should be screened for fecal occult blood in his stool.
Okay, doctor. So, what is the positive signs in this patient?
Yes, has postural hypotension,
Okay.
has peripheral neuropathy,
Okay.
and in auscultation also there is atrial fibrillation,
Yes.
which
Okay.
may be one of the causes why he was dizzy if he has any attacks of rapid ventricular response.
Okay, doctor. Any other positive signs?
From examination, I didn't
Yes.
find.
Okay. The patient has bleeding vision. So,
Yes,
are you?
I will refer him for ophthalmologist to do visual assessment, field, and retinal examination, fundus examination to
Okay.
see if any retinal diabetic retinopathy.
Okay, doctor. So, tell me, please, the visual diagnosis of this patient.
So here may be a dizziness due to diabetic neuropathy, especially autonomic neuropathy, maybe due to atrial fibrillation,
Okay.
maybe hypovolemia. In case I will assure that's no diabetic ketoacidosis because he has discomfort in his tummy, and also I would
Did you check the blood sugar of the patient?
I am asked to do this examination.
Okay, doctor. So,
And also for his kidney, if this uremic.
yes, okay, doctor. So, any other diagnosis?
Here the patient has many risk factor. I want to see also his carotid and if this transient ischemic attacks.
Okay, any other diagnosis?
Here, because of a long history of diabetes and uncontrolled, maybe silent ischemia.
Okay, but the patient doesn't have any chest pain. Okay, silent ischemia. Okay, okay, doctor. Any other diagnosis?
Here in this case of diabetic, but I think because he has no other, maybe Addison disease,
Yes.
autoimmune polyglandular endocrinopathy
Yes, doctor.
was associated with Addison, but he doesn't has any shaking of hands or pigmentation on examination.
Okay. Okay. Wait, tell me what is the clinical the investigation? What would you do for this patient?
I want to complete the examination with doing fundus examination and testing visual acuity and also neurological assessment, investigation, complete blood count, kidney function and electrolytes, liver function test, albumin creatinine ratio, EPG to see any acidosis. I will do urine test to check for proteinuria and also ketones in urine. I will do ECG and echo and carotid duplex.
Okay, doctor.
And
Any other investigation?
And neurological manifestation, and to exclude also hemoglobin A1C and the blood sugar, of course, and to exclude the Addison disease. I want to do basal cortisol.
Okay, doctor. So, what do you think about lose weight? What is the cause of lose weight in this patient?
Losing weight here is significant. It may be due to Addison play a role, or maybe malignancy, underlying malignancy. If the case, for example, the responsible cause for is acromegaly, for example, maybe more predisposable for colon cancer.
No, it is not acromegaly, Dr. Ahmed.
Okay.
Okay, what will you do for this patient? What
Here
will you
is the change
for lose weight?
A change in bowel habits, and in this age, I will consider colonoscopy to investigate for colon cancer and occult fecal blood in stool.
Colonoscopy. Okay. Okay. What is the treatment of this patient?
Treatment of the patient, multidisciplinary team approach, including nephrologist, diabetologist, neurologist, ophthalmologist, and specialized nurse, and also gastroenterologist. Non-pharmacological and pharmacological. Non-pharmacological, patient education and counseling about his disease. Also, dietitian should be included to better control of his blood sugar, and the treatment of the underlying cause. If, for example, diabetic ketoacidosis, I will admit it to ICU and give IV fluids and corrector of his high blood sugar. If the kidney should be better control his blood sugar. And if the case, I will do 24 hours ECG if any phases of high risk. I will.
Okay. Why 24 hours?
To see the burden of the AF for how minutes is tachycardia or how hours.
Okay, doctor. Okay, Dr. Ahmed. The treatment, this patient came with dizziness. So, what is the treatment of this dizziness? Any advice for the patient? Any advice for the relative?
Because there is autonomic neuropathy, there is
Yes.
here plenty fluid intake, not standing rapidly while sitting, maybe stocks.
This is a vasovagal dizziness, not the autonomic neuropathy.
Maybe for the pain, but the against pain and numbness, neuropathic pain therapy, pregabalin.
Okay, Dr. Ahmed. Thank you very much.
Thank you.
Okay, Dr. Mahmoud. Thank you, Dr. Ahmed.
Okay.
Well done.
Well done.
Dr. Mahmoud, you can comment now. Then
Yes. Okay, Dr. Ahmed. Well done. But I think you have to be. This case is dizziness. So you told many information other than this patient. What I mean that this patient came with dizziness. Okay, that is my case in the second diet in Alexandria. The same case. Outside it was dizziness, 65 years old. When I came into the inside, I think you should ask about okay, what your father have? He will tell you that my father has these spells. So you have to analyze the business from A to Z. What I mean that before and during and after. Okay, I think you will lose more degree in the clinical communication. First of that, you have in the feedback of my case, he writes that the candidate doesn't ask about the vertigo. So before analyze the business, you have what do you mean
Yeah,
about the business? You mean that your father have these spells, or he has spinning around the room, or the room is spinning around your father?
I have
So
written that, but I didn't ask.
yes, so you will lose in the clinical communication. The surrogate will tell you that no, doctor, he have these spells. So you have to analyze the business. Which is the business is cardiogenic or neurocardiogenic. Sorry, it is neurogenic or cardiogenic or neurocardiogenic or posture hypotension. So before that, what were your father doing? I will tell you that my father, this business happened when walking, and also when he was sitting, when standing, like that. So you will ask, does your father have these spells when standing from sitting position? Yes, doctor, he have that. And also your father have dizziness when he is walking. Yes, doctor, he has also dizziness when he was walking. So going into the analysis of the dizziness. Okay, during this dizziness, did he lose his consciousness? No, doctor. He doesn't lose his consciousness. He didn't lose his consciousness. Okay, does he have any abnormal movement, any jerking in the limbs, in his arm or leg, to exclude neurogenic cause? No, doctor. He doesn't have any jerking in the limb. Okay, did he measure? That's the most important thing. Did he measure his blood sugar and the blood pressure during these spells? No, doctor, he doesn't. Or the surgeon tell me I don't know. Okay, so after the business, okay, after this business, how the attack end? He may take some blood sugar. He may take any pills. I don't know. The surrogate will tell you, I don't know, doctor. Okay, did he resume his activity fully conscious? Yes, doctor, he resumed. So that is analysis of dizziness before and during and after. And the examiner really notice this analysis before and during and after. Okay, with the analysis, this posture hypotension. So we have to go deep into the past history. Okay, what is the past? Any long-standing disease in your father? Yes, doctor, he has diabetes and hypertension, and also take apixaban and enalapril for hypertension. So in your mind, enalapril cause posture hypotension also, and the apixaban, you have to analyze the apixaban very well about any bleeding from any orifice, any change in the dose. Um, okay, so the past medical history was diabetes. So we have another another complaint is that diabetes. You should analyze the diabetes as well. Any past history of heart attack, any past history of stroke or mini stroke, and you should ask every question as a separate. Don't ask two questions in the same. And also, does your father have any fusion, any blurring of vision? And also, you forget in this case about the intimate relationship. And really, there is one examiner. He noticed that about the impotence in the diabetes. If you forget to ask about the impotence in diabetes, you will lose many marks. That is in Egypt. Okay, and also in diabetes, this patient has long-standing diabetes from since 20 years. So you have also ask also about hypoglycemia awareness or unawareness. What is the importance of this? That about the driving, the advice of the patient. So you should ask the surrogate, did your father have any history of low blood sugar? He will tell you, yes, doctor, he has a history of low blood sugar. And he admitted one time since 1 month in the hospital. So the next question, does he aware about the symptoms? And you should explain what is the symptoms of hypoglycemic unawareness. When he has these symptoms, does he have any shaking of the hand, any heart racing, any heartburn? No, doctor, he doesn't feel anything about that. So this patient is hypoglycemic unawareness. After that unawareness, you should stop driving directly. That's the most important thing. So this patient have hypoglycemic unawareness. So we should search about what is the cause of hypoglycemic unawareness. The first important thing is autonomic neuropathy. So when in the history, when go to the systemic analysis, does your father have any throwing up? Yes, doctor, he have many times throwing up after meal. Does your father have any discomfort after meal? Yes, doctor. Does your father have any loose stool? Any problem in the stool, like loose stool? Yes, doctor. He has many times going to the bathroom for loose stool. So it is autonomic neuropathy and unawareness. You should go deep. Okay, and then you should examine early. After that, you take the case. You should examine early. First of that, examination of diabetes, and you have now two examination of diabetes and the examination of dizziness. Okay, first the dizziness, that is a complaint. First, you should ask about the observation chart of the patient, blood pressure, sitting and standing. When the examiner tell you, yes, there is difference, you should tell the examiner what is the difference, above 20 or systolic above 20 or not, because maybe there is difference, this is normal, maybe 5 or 10. So it is no difference between sitting and standing. So the examiner tell you, yes, it is over 20, and you should ask for blood sugar. This patient came with dizziness and he is diabetic, so you should ask for random blood sugar and the temperature also, and you check the pulse in the hand. Yes, you check the pulse in the heart, but the examiner, believe me, if you don't put your hand in the pulse and check by your watch, he will lose you the markers already. So you should put your hand in his arm to check the pulse. Okay, it is no problem. And go up to the examination of diabetes. Examination of diabetes, three things, the most important thing. The peripheral neuropathy and the eye, okay, and the abdomen. Okay, first we will, in the inspection, you should inspect, every one of us forget that, the needle pricks in the hand for measuring of the blood sugar. You should also notice that. And then you should examine the peripheral neuropathy, about the sensation of the patient, and also the tone. Neurological examination, but fast. But the most important thing is peripheral neuropathy. And you should examine the leg. Examination of the leg. The examiner should notice that you examine the leg very well, between the finger and in the dorsum of the leg, and also in the bottom of the leg. In the dorsum for Charcot joint, and between the finger for any fungal infection, and go up for peripheral neuropathy and check the sensory level, maybe the sensory level above the knee. So the patient should examine the sensory and determine what is the level of sensory loss. Okay, and then you should examine the abdomen for any lipodystrophy, for insulin injection, and also the liver and the spleen. Okay, and then go to the heart, because the patient is AF, atrial fibrillation, and you should examine the heart very well, especially in the aortic area, and also in the parasternal area for HOCM, May the patient have also family history of cardiac death. May patient have HOCM, but he doesn't know. Maybe. And also examine from the back for bilateral basal crepitation. Okay. Okay, about losing weight. Patient lose 5 kg over 3 months, and the patient have abdominal discomfort. Okay, patient, you should ask about, you ask already about any bleeding from back passage, but also you should ask about any black stool, because the patient may have gastric ulcer, maybe have gastric carcinoma, and doesn't know. So you should ask about that for the skill of in clinical communication. Okay, you didn't ask about any social history, any smoking, any alcohol, because the patient may take alcohol. That is the cause of hypoglycemic unawareness. Patient is already alcoholic and he take many alcohol before sleep. You didn't stop driving in this patient. This is really big mistake, Dr. Ahmed. You ask about this drug history, medication, smoking, driving. Yes, you didn't ask about any family history of this patient. Okay, most important. Okay, going on the examiner question. Okay, the examiner tell you what is the yes, positive signs. You tell it very good, but you didn't offer fundoscopy of this patient. This is also big mistake. Although the examiner will not offer to use of the fundus, but fundoscope, but you didn't want the fundoscopy. Okay, going to the differential diagnosis. This is a big mistake. Yes, first of all, this may be autonomic neuropathy. Yes, the presentation of this case, you should tell the examiner this patient has, like you said, patient has posture hypotension for differential diagnosis. Okay, for what is the differential diagnosis for posture hypotension in diabetic patient? First of all, autonomic neuropathy. Second, maybe anemia for chronic disease. Third, drug-induced, a patient on ACE inhibitor, so maybe posture hypotension because of the drug-induced. Yes, anemia. And this, fourth, maybe arrhythmia, patient is AF, so maybe arrhythmia. Also, yes, no, the second one is Addison. You should exclude Addison in this patient. So differential diagnosis. First, autonomic neuropathy. Second, adrenal insufficiency. Third, arrhythmia. Fourth, drug-induced. Why I put drug-induced number 4? Because patient is in April since 5 years, so less likely to cause posture hypotension. Number 5, maybe anemia. So the examiner will tell you, okay, what is the cause of anemia in this patient, and what is the cause of lose weight? You tell good, but not that. Yeah, like what I mean, patient has abdominal discomfort, okay, and also has lose weight. Why you think about colon cancer? You should think about any gastric cancer. Patient has abdominal discomfort. So the cause of lose weight may patient have because of first autonomic neuropathy, cause lose weight, and the second patient may have gastric cancer. So in the judgment, you should do upper OGD, the most important thing in this patient, and the examiner in this case ask me, what will you do for this lose weight? What will you do? I can't do anything. So he write in the feedback he didn't do upper OGD. So that's the clinical case. In the clinical judgment, yes, you do very well. CBC, looking for any anemia, and also hemoglobin A1C, okay, no problem, and EPG, it's very good. And also you do ECG and echo, but you forget Holter. We should do in this patient Holter, not 24 hours cardiac monitoring. There is difference between lead recorder and Holter. If the palpitation did within 7 days, so you should do Holter, not lead recorder. Lead recorder if the palpitation less than 24 hours. So you forget Holter in this patient. Also, we should do our OGD for this patient. That's the clinical judgment. What else? What else? Yes, I think we should do this patient tilt table test because the patient has posture hypotension. In the treatment of this patient, most important thing is patient advice. Non-pharmacological patient education and counseling about his condition and the patient advice and let someone know about his condition and to make his blood sugar higher than the normal and also the injection of glucagon. That is the advice of autonomic neuropathy or hypoglycemic unawareness. And the most important thing is frequent blood sugar monitoring, like any glucose, any monitor, the sensor. And the treatment will be the Mutilin or like Domperidone or like that. I finished already, Dr. Basim.
Okay, thank you, Dr. Mahmoud. I will start from the point of Holter, because this is the recent point you mentioned. If the patient is already having AF, why I should do the Holter? He
Yes,
has
patient.
already ECG with AF.
Yes,
I want to correlate with the event. If that's happen while walking, then have evidence to see in Holter or 24-hour ECG. That's if there is any high heart rate or tachycardia.
Yes, a patient
Okay,
has.
you mean other arrhythmias, right?
Yes,
Other arrhythmias.
yes, Dr. Basim.
Okay,
I told
So,
the patient lose this arrhythmia, not rapid AF.
okay, yeah,
Because the
okay.
patient was, in my case, in the exam, the patient was controlled. The patient doesn't on beta blocker or anything for rate control. Patient only or for on apixaban and already AF. So patient controlled without any rate control.
So you want to confirm other arrhythmias?
Yes,
Don't
Dr.
say I
Basim.
want
Yes.
to pick up the AF because
No,
he's
no.
already AF. Okay.
Yes, Dr.
Yeah,
Basim.
okay, I
Yes.
heard that wrong. Okay. This is the first point. I want to clarify it for all, not for only you. The second point, whenever you have patient lives alone, it's very important, Dr. Ahmed, to admit him
Yes.
initially, to admit
It's
him
called social admission.
exactly, and don't discharge him unless you find a company with him. And don't go to the social worker first. You have to ask the family to arrange someone to live with him or to be accompanying. If not, you can ask for other friend, for family member. If not, the last option will be for social worker because social worker are not free to have a company or to arrange this issue. Later on, if no one can help, then you can admit him to the home. What we call it, Dr. Omar?
Social admission. They like the term if you use social admission. Some
Social
patient
education, yes.
can be admitted because if imagine the scenario, a patient and his wife is admitted, and his wife is his carer. We admit both the patient and his wife. His wife, they call it social admission because his wife is in another ward and she is reliant on medication and she can't give him medication herself.
Okay. No. I want to say for the elderly who can live with.
Residency, elderly residency.
Yes.
Elder residency. If you are outside UK, if UK, it's a care home.
I think in the UK they have a center or for those elderly people, right?
Yes, but if the
Otherwise,
patient,
yeah, continue.
if she just for living at home with and she's independent or the patient is independent usually and he takes his medication but he's now doing poorly and he cannot take care of himself for a short period because of his illness. He needs to be admitted to be assessed internally, as you said, Dr. Basim, and then they do an inpatient social team whom will assess, including physio and occupational therapist, to see if the patient does have a new baseline. Therefore, they need to put a plan for the outpatient social team. So the
Perfect.
wisest option for this patient is to be admitted for social reasons.
Perfect. Yeah, it's very important. It will be affecting your clinical judgment and welfare. Never ever discharge or tell the examiner, I can arrange for OPD for this patient. Okay, it might affect the mark dramatically. So I should admit this patient. What else missed in the clinical communication or the history taking? Totally the family history. Here it's fatal. If you have cardiac arrest or cardiac death in the family, it's crucial to ask about it.
And
Uh,
cancers.
and cancer, of course, because there is a loss of weight. Okay. What other point I want to say? Yeah, the alcohol, as Dr. Mahmoud said, the alcohol here is something also essential to have it as a history. Why? Because it will interfere with the hypoglycemia, or it can lead to hypoglycemia. Initially, awareness, then it will be unawareness, hypoglycemic unawareness. So you have to take it as detailed alcohol history. Smoking, of course, as well. You have to ask about it, and driving. The three do you didn't ask them at all. Do you smoke? Do you drink alcohol? Do you drive? And all of them have impact on the patient. So you have to ask all of them. I think either borderline or maybe also some examiner, the tough examiner can give you unsatisfactory in the clinical communication, because these things are important to ask. I prefer to ask to start with the long-standing disease prior systemic review or before asking the systemic review. Why? Because if you have diabetes, or you will repeat the old question for diabetes again after you finish the systemic review, and it will take another 2 to 3 minutes. You already did that. You ask about mini stroke or stroke. You ask about heart attack, which is one of the question, or these question can be added to your systemic review. I shared my favorite approach for this reason. For 60 or 50 plus people, please start to do the relevant system after the complaint analysis, the relevant system analysis, and the constitutional symptoms. The next thing will be long-standing disease, history of surgical admission, any surgery, any procedure, allergy, and of course the past medical history. As I mentioned, the long-standing disease. If you have diabetes, put your approach for diabetes in the systemic review. For the CNS, I will add stroke or mini stroke. For the cardiovascular, I will add heart attack. For the kidney, I will add the foruthness, for nephropathy, I mean, and the legs or the weakness for peripheral neuropathy. And the impotence, again, for the autonomic neuropathy. And for the GI, don't forget the early satiety. Patient will have or will feel fullness after small amount of food. All of them are questions related to the diabetes analysis, and they are in the systemic review. That's why I prefer to do them during the systemic review. And
With
as you
relevance
did,
to diabetes, Dr. Basim, can I ask Dr. Ahmed the difference between gastropathy and autonomic, the feature of the gastroparesis and the autonomic neuropathy with relevant to the GI symptoms in the patient of diabetic?
Gastroparesis, it is one of the complication of autonomic neuropathy. I can speak
How he will
while
present?
asking any is that discomfort related to the meals, and also asking about dumping. Do you feel any dizziness after eating?
Would he be having diarrhea or vomiting?
Gastroparesis, dumping with more diarrhea. So
He will be having more likely he will be having vomiting. But in the autonomic neuropathy that's affecting the small bowel or the peristalsis, it will cause diarrhea. So diabetic patient with frequent vomiting, and it might can cause consequent ketoacidosis, nutritional ketosis. He can't eat. He's admitted, or he's coming because of repetitive vomiting because of because of his gastroparesis. If it is more with autonomic neuropathy, he will be having diarrheal symptoms more likely.
Yeah, perfect.
Oh,
And with the poorly controlled diabetes, you will have most of them. Okay. And the most important here for the driving, as well as for the diabetes itself, the hypoglycemia. Never ever analyze diabetes without asking about low blood sugar episode or attacks. All of us, or most of us, doing the analysis of hyperglycemia and complication of hyperglycemia, but we usually forget the low blood sugar or the hypoglycemia. And as you know, and everyone knows, it's more dangerous than the hyperglycemia. Some people and some patients might be losing their life because of hypoglycemia and awareness. That's why it's very dangerous, and you have to ask it as well as you are asking about the hyperglycemic complication. It's very important, okay? So whenever you ask about the hyper, give one question for the hyper. One question. Have your father ever had any hypoglycemic or low blood sugar episode or attacks? Yes or no? If yes, analyze it. When that happened, is it recurrent? If he's aware about it, and you can put it immediately one of your differential. Hypoglycemia, one of the differential of syncope. Of course, along with the manifestation of hypoglycemia, sweating, hunger pain, the feeling unaware, or later on the patient will be in coma.
Yes.
Okay?
Uh, how to screen for the awareness, Dr. Bassem? I feel the golden question in diabetes. If the patient tells you that I'm monitoring my blood pressure, my blood glucose, so he's a keen patient, likely if he tells you yes or no, you can rely on his answer. But if he told you in the beginning that I'm not keeping up with that, you if you asked him, are you aware or not, or this kind of question, he will give an answer that's contradictory. But I'm trying to think how um, to go to give a golden question that would cut you short in time, because if the diabetes is there, there is so many questions to cover.
You
Did
mean
you
the
get my
liver
point,
machine?
Doctor?
Yeah,
Not only Libra machine, but if I was thinking of if we started to ask the patient from diabetes, how's your control? He will tell you that when was the last one, when was the last accumulated glucose
yeah,
in your blood. He will tell you the last
yeah,
one was last month or in the last 3 months. So he's keeping up with his follow-ups. So likely he's an educated patient, and you can
yeah,
rely on
perfect.
his answer. But if he tells you that, or from the scenario you are smelling
Yes.
that he is not compliant, then likely he will not be aware that he's having hypoglycemia. This is what I'm thinking about.
Yeah. Whenever you have the hyperglycemic complication, believe
Yeah.
me, you might have the hypoglycemia as well. So it's important to roll them out. In particular, our scenario today, the dizziness or syncope or fainting or seizure, anything can be life-threatening. You have to analyze the hypoglycemia. Okay. Usually, you have to ask also about the diet, the exercise, and the rotation of the insulin. But it's very complicated case to ask all these questions. The most important to do the complication of hyperglycemia, as we said, the neuropathy, retinopathy, nephropathy, and autonomic neuropathy. Okay, peripheral neuropathy or autonomic neuropathy. Again, the retinopathy and nephropathy, and the of course heart attack or stroke or mini stroke. Then the question for hypoglycemia, you have to put it in one sentence or at least 1 minute analysis. If you do so, you cover the all insulin sorry, the all diabetic analysis. Follow up, you can add also to the questions, diet, exercise. Sometimes the time will not allow you to ask all these questions. In particular, if you have such scenario, fainting, I have to analyze prior or before, during, and after. And the question Dr. Mahmoud mentioned, how I regain my consciousness, did I lose the consciousness? Did the patient had any biting to the tongue or become blue, lose the control over the bowel or the water work? This is going with the epilepsy. Or you will find the patient is having heart attack, palpitation, or awareness of heartbeat. You will think about arrhythmia. Or you will have patient with diabetes, poorly controlled autonomic neuropathy might be there, or hypoglycemia as a differential as well. So it's a complicated case. It's a case of differential. I believe it's not a case of one diagnosis. They will look how you are analyzing, putting good differential, ruling out the most dangerous. For me,
Yes. Mm.
in such scenario, the hypoglycemia most dangerous one and should be rolled out. And I put it in the differential. As Dr. Mahmoud said, I want to check his blood sugar. Put it in your examination question as a vital. Can I know his blood sugar now? Okay, this is a very important question to ask during doing examination.
Or you can ask
Um,
for the blood sugar diary, like are you keeping your diary? What about this question, Dr. Basim? What do you think?
Again, what the question?
The blood sugar diary. If the patient doesn't have Libra device and he's monitoring his blood sugar, he should have a diary.
Okay, I think if the patient is having Deber machine, he will be a good
No, Libra
controlled
machine
one.
here, it will be in his mobile. Yeah, it will be in
Yeah,
his
he
mobile.
will be a good controlled and compliant patient.
Mm-hmm.
Okay, why? Because it's giving alarming continuously all over the day, right? Second by second. If it's low, it will alarm him. If it is high, it will alarm him. So he must be controlled. Unless he is also ignoring this machine, so what the benefit? But suppose if he has the machine connected to his phone, means that he's compliant. By the way, if you have a scenario with diabetes and they want to give you no complication, they will tell you from the start, yes, doctor, I am well controlled, and my last blood sugar for 3 months, 7, for example, or 7.5. Don't think about other complication, or you don't expect you will have the all complication or any complication. But you have also to ask about the hypoglycemia. Did you ever have hypoglycemia or low blood sugar? Don't say hypoglycemia. It's a jargon. Did you ever have any hypo or low blood sugar? Yes or no? Then continue other analysis or systemic review according to the case. But today case related to the diabetes, definitely you will have finding of poorly controlled diabetes, either hyper or hypo, or the palpitation, the AF. Related to the AF, I want to add one important information, not as today case, as cardiac case. What the importance of examining the heart if I have AF? What the clue behind it?
The valvular atrial fibrillation or non-valvular?
Is the patient
Perfect.
inferior or not?
Not only failure, this is what I want to ask about the valve. Why the AF happen? Usually AF happen because of what?
Mitral
What the
regurg.
most common valvular?
Mitral stenosis.
Mitral
Yes,
stenosis.
mitral
Yes.
stenosis. Yeah, this is my question. So it's commonly associated with mitral stenosis. Whenever you are in the cardiac station and you have felt the AF or irregular pulse, expect the patient is having mitral pathology. Commonly, in brackets, the mitral stenosis. But you might have also mitral regurg.
But again, is that in this scenario that the patient was on apixaban? If he does have
No, no, no.
valvular, even I know. I'm just
Yeah, in
telling you
general.
in
Yes.
general. So
I'm talking in
if you
general,
ask it,
yes.
if you ask it about if you ask it the patient medication list and you found apixaban, less likely to expect mitral pathology. But you can find mitral pathology, and you are the first one to discover that. But did you get my point?
Yeah. But
Mm.
it usually it comes as a cardiovascular station, not
Yeah.
as lung scenario.
Yeah.
Here, here, as a differential in such age, very important pathology or valvular pathology can be the cause of the syncope, and it was one of my cases in exam. What could be the case?
Aortic
Valvular.
stenosis.
Perfect.
Oh.
Yes. Aortic stenosis, you can put it as a differential for any syncope. So you
Yes.
might have the murmur of aortic ejection systolic murmur
Yes,
radiated
doctor.
to
But
the
in this
carotids.
case, in the Alex, the surrogate told me, yes, he had palpitation but no chest pain. So to exclude any aortic stenosis or like that.
Perfect. Yes. So
Mm.
it might be there. Or you might have sclerosis as a differential to aortic stenosis, but
Yes.
usually the symptomatic one aortic stenosis. So you will have the murmur, and you have you can feel it over the carotid, and you can also auscultate over the carotid for bruit. Okay. We are done. I think Dr. Ahmed just need to organize the history and put it as package. As usually saying, I'm saying take the question as a package. Whenever you ask for constitutional, ask them together. Don't ask about the weight and ignore the appetite. So whenever I ask about fever, night sweat, the weight, what about the appetite? Why did he lose the weight? Is it because of poor appetite or just intentional? So put the question two question together. What about his appetite? Yes, doctor, he lost his appetite. Now you have to put alarming differential, which is cancer colon, for example. Okay. The other package, do you smoke? Do you drink alcohol? Do you drive? The last one, social family history, HIV question, and the HIV including the casual relationships or even the relationship itself. Here, one of the autonomic neuropathy finding will be impotence, and you can do it as a screening of any casual or any relationships. And if he has a partner, how is his relationships or how is his desire? Okay, he will tell you, doctor, I cannot maintain the erection. I have a problem with my intimacy, whatever the president. But don't forget to be sorry for this question. The systemic review, of course, you have to do them together. And earlier, as I said, the analysis of the complaint, the irrelevant system, constitutional symptoms, and the important part, long-standing disease I should be aware of. Okay, do you have any question, Dr. Ahmed?
I have
Yeah, any,
now the case for diabetic, but time management in this case very difficult, either
do
in
it.
history taking or examination.
You have to do it. You have.
Very well
The,
treated.
yes, you have to train on diabetic and hypertension. By the way, nowadays they brought these scenarios commonly. The
And in
diabetes
this diet,
with the
yes. In this
complications.
diet, yes. In this diet, yes.
Yes,
There is
yeah,
one scenario that will become for differential diagnosis and a lot of talking.
exactly. And I think from now onward, it will be like this: diabetes with chronic illness, complication, manifestation, and one acute presentation. So you get ready to have both type of scenario. Not only diabetes. The other thing I want you to do, the hypertension. Patient with hypertension uncontrolled, he took medication, it's not still not controlled. He's young, so you have to rule out the secondary causes. You have to reach, is it essential or something related to other pathology. Try to do it as a differential, again with a systemic review. So you will have with every question a clue for an answer. For example, if you have patient with hypertension and he has an anxiety and sweating, so I will suspect pheochromocytoma. Or, for example, another patient with valvular heart disease, aortic stenosis, or during the examination, I will find there is discrepancy between the pulse, the radial, and femoral one. What I should expect?
Coarctation.
Coarctation of aorta. Yeah. So do it in this way. You have to know how to screen for hypertension. If all of them will be negative, then I will think about essential hypertension. And don't forget the white coat syndrome and the herbal remedies like licorice. Okay?
Oh,
Yes.
Three last point to touch with in this scenario. When Dr. Ahmed mentioned about the Romberg, yes, you can use it but to say likely pointing to peripheral neuropathy, because it's not the ultimate sign for
yes,
peripheral neuropathy, especially if you didn't do a full examination of peripheral neuropathy.
I should ask for
Okay?
monofilament examination for.
No. If the time can't allow you, but if you did Romberg and you've Romberg is positive, and the examiners said to you, "Do you think that you have completed? Have you tested for peripheral neuropathy?" You can use what you've done. I've tested only for Romberg, and it is positive. So likely, in this patient, it is pointing to that.
Yes.
to use the phrase likely, so you are telling them, I am aware that there is other causes for positive Romberg, but I'm thinking in the context of this case that it is likely due to peripheral neuropathy. And they will like
Perfect.
that. But the other candidate who said, I did Romberg, he will challenge him. And they will do this on purpose. Have you tested for, have you examined for peripheral neuropathy? He will tell you,
Perfect.
you will tremble yourself. So you've done it so well, but to to use the word likely is a golden word.
Yeah, this is what we discuss in the chat box. Everyone can read. I ask about this part because Dr. Ahmed did, I think this is fatal mistake to say, I assume, or you assume that the patient is having peripheral neuropathy because Romberg test is positive. Although the Romberg test is positive with other sensory ataxia, including the dorsal column affection. So why you are saying this patient is having peripheral neuropathy? As Dr. Omar said, you can say likely it's peripheral neuropathy because he's poorly controlled diabetes, but don't assume because it is peripheral neuropathy.
Yeah, likely in the context of this case, to use these three buzzwords, likely in the context of this case, or relevant to the patient age, gender, and ethnicity. They will like to use that if you are having, especially in hematological conditions. Okay, so given considering the patient age, ethnicity, and gender, it's likely to be hereditary spherocytosis or thalassemia or whatever. So these buzzwords will save you a lot of talking, and you can say them in less than 3 seconds. Okay,
Yeah.
did you get my point?
Yes,
Unless,
doctor.
unless Dr. Ahmed, you did the peripheral neuropathy examination. If you
Yeah.
did it, yeah, definitely you can say I had peripheral neuropathy evidence by my examination. Then it's positive for peripheral neuropathy or for the Romberg test or Romberg test because of peripheral neuropathy in this way. Okay.
But even Dr. Basim, he will lose marks because he didn't check peripheral neuropathy. So
But
it
Yeah.
is
he
better,
justified.
yes, better to examine, no, better to examine Neil on the shaft examination when closed the eye. It is the same as Romberg test. Romberg test will take time, more time.
Yeah,
Mm.
Okay, but
yeah,
it's a
I
good
agree with you.
confirmatory test, by the way. It's one of the confirmatory tests to confirm the peripheral neuropathy.
Yes, Dr. Basim, it will
Of
take
course,
time.
after
Yes. Mm.
doing the
Neil on
sensation
shaft.
examination.
Yes, Dr. Basim. That's what I
Yeah,
mean.
knee
To be honest,
examination.
And also to memorize complication of diabetes, I always memorize like that: three macro, and autonomic and hypoglycemic symptoms.
Okay,
So
mention
it
it
is
as
nine.
the last point of discussion. Then we'll move
Yes.
to the second
Okay,
part of
Dr.
test.
Basim.
Yeah, mention them, please.
Okay, doctor.
uh, the other thing is the
No, no,
for Addison.
Dr.
Oh,
Mahmoud,
Yes.
say them. The
Yes.
three.
Okay, three macro,
Mhm.
and two. One for autonomic neuropathy, impotence, and one for hypoglycemic symptoms. Okay, three micro, blurring of vision, fluorescent urine, and pins and needles in the hand and the feet. Okay, that's three micro. Three macro, it is stroke, heart
Coronary
attack,
artery. Yes.
yes, and any pain in the back of the leg when walking. That is the three macro. And one impotence, and one for hypoglycemic symptoms. So all of them is nine.
Yeah, perfect.
I
and will take
always
less than 30 seconds to ask about them.
yes, that is the point, Dr. Omar. So three macro,
Mm.
and one impotence, and one hypoglycemic symptoms.
You can write them in the chat box for other candidate.
Okay, Dr. Basim,
Yes.
and to summarize this case of dizziness in diabetes. So you have to analyze the dizziness and to know what is the cause of dizziness, cardiogenic, neurogenic, or pulmonary hypertension. And the second, to analyze the diabetic complication, which is the nine complication. So it will take, I think, in the history, it will take 6 minutes, and then examine diabetic examination, which is peripheral neuropathy, and the foot is the most important thing. If the patient has Charcot joint or any ulcer or any fungal infection, it will be a problem if you forget that.
Missed it.
And yes, and also the eye and the abdomen for lipodystrophy or insulin injection.
Okay. And the
That is the
Joker,
case.
our Joker in any case,
Yes, drug induced.
perfect.
Yes, Dr.
Um,
Bassem.
how to
Yeah.
test for this is advice for Dr. Ahmed, how to test for peripheral neuropathy quickly if you are short on time is to take the needle if it's available on the table and go ascendingly asking the patient if there is any if the needle becomes sharp. I know that in overseas center you are examining in Arabic, so it will be easier. Does it feel sharp? You can say it in Arabic. Does it feel sharp as I go up? If he said yes, at what level? Then you've proven the glove stocking. So you can use this
Yes.
to justify. If you are short on time and you can do this only, this is to justify, to prove the peripheral neuropathy as a solution if you are short of time.
Perfect. Okay.
The two last point is the morning cortisol. In Addison, you do morning cortisol, not 24
Mm.
hours. 24 hours in Cushing.
Yes.
The
Yeah.
last thing, Dr. Mahmoud asked Dr. Ahmed a specific question. In this patient, why do you think that this patient is losing weight? So the differential for diabetes, losing weight in diabetes, insulin depletion first. He's becoming insulin dependent now. Even if he takes insulin, he can take insulin early because of his glycemic control, but this doesn't mean that he's insulinopenic or deplete his pancreas has depleted from secreting insulin. The second is cancers, and especially if there is diarrhea, other alternative diagnosis is glucagonoma, which is a pancreatic cancer also as well. The third is to consider celiac, and its upcoming trend right now. In elderly, to consider celiac. You say it's less likely in his age group, but it is now being, I wrote it in the chat box, but it's becoming increasingly found recently. They like to hear that.
Okay. Thank
Thank you.
you. Especially if there is a female, right?
Female or even male,
With
but you can
autoimmune
say,
association.
yeah, you put it low. If the patient doesn't have autoimmune association, but this patient gives when he had diarrhea, he mentioned that it has some relation to food, and you didn't clarify. If you didn't clarify what type of food, you have to put it in your differential because I didn't clarify it correctly. We can send the TTG. No harm in sending the TTG.
Okay. Thank you, Dr. Omar and Dr. Ahmed, Dr. Mahmoud. Any question before open the mic for our candidate, Dr. Mahmoud, Dr. Aisha? Sorry, we'll start with Dr. Aisha, Dr. Who else attend? Dr. Aisha, right? Dr.
Yes,
Shahla.
okay.
Who else? Our candidate who passed last week. Yes, Dr. Aisha. We'll start with you.
Okay.
Congratulations first.
Hmm,
Congratulations. Many,
thank you,
many
Dr.
congratulations
Bass.
after a long time. And this is a
Yes.
continuous hard worker, persistent to and insistence to pass this exam. I feel
Yes.
sorry. I feel sorry
Alhamdulillah.
for those candidates who give up. Wallah,
Yes, this is
I
the
heard
aim
about
today,
it.
really.
Yeah. Okay, you can
I
start. The
need to
mic
give
with you.
hope. Yes.
Okay, you can start, doctor. Tell us about your experience. Yeah, as short as you can, or whatever you want to say. We are here to
Okay.
hear you.
So, okay, so 1 minute, please.
It's okay.
Sorry.
Take your time.
Okay.
Dr. Mahmoud, anyone else attend? Dr. Shahla attend or no? I don't think she's with us. And Dr. No, she didn't attend. Okay.
Dr. Omar, Dr. Bekinam, I told
Okay.
him.
Dr. Buckingham also not here. Anyway, the one present who can start, Dr. Mahmoud, you can tell us
Yes, if
what
Dr. Omar
the advice.
in hurry, he can start. No problem.
No, I'm not
I
in
am
hurry. No.
No,
I'm enjoying.
Dr. Omar, mashallah, he cannot do it in hurry.
okay.
He
Not
had a lot of talk, mashallah. So if you want, well, let's start with the who can be busy later on. Dr. Aisha, if you are still busy.
Okay, you can hear some noise. Okay, no problem. So,
It's okay.
it is a
Yeah.
part of the journey. my
Yeah,
children.
exactly.
Okay.
Yes. They are
So,
important for our journey. Continue, Dr.
yes,
Ash. Yes.
yes, it is
Move
part
on.
of struggle, really.
Yes.
Thanks to Allah. Is the one with me always. Alhamdulillah. Really, it was a hard journey, but the best thing I know a lot about specialty, and also very like priceless gift of friends in this journey. So with my journey, really, at first I was thinking that only studying you will pass with it. But this basis, I learned that it is 3 parts to pass, and it is always from God, but it is 3 parts. Studying is 1, practicing is 2, and the third one is like confidence. You should have confidence. So I entered the exam 3 times. First time in Jordan, then Kenya, then Egypt. So I returned back to Egypt. Really, I applying for Egypt in time, but I have no seat. So I trying outside Egypt. So this time I went to Egypt. I go to Egypt without like preparation. I just finished the Kenya exam, and with bad experience. The problem was that I know myself that I have, like, if I have in strange country, strange tradition, strange people, so I'll have less confidence than in my original country or a country speaking like me, or I know them. This is different from person to person. Everyone should know himself before applying, before deciding. So if you know yourself, you will know what you will decide about yourself. The journey, I learned from it a lot. And I thank God about fail before success, really. Because every fail I learn about from it a lot. In fail, the causes was many, but the first thing is the hesitancy and not to be confident, and the very tough examiner that you should be very confident with them, because they trying to make you like hesitant about yourself, to make you like very anxious and lose your temper, like that. So they trying to do that. It's not luck. They trying, really. They enter the exam trying to do that, to make you like lose your confidence. They didn't test only the information in this exam. They test you are a very confident doctor. You are stable. You are, and really in the real life, you will not facing like that in your real practice. So that's not really fair, because everyone in exam should be slightly worried and anxious. This is normal people. If they need from us to be not normal, abnormal. So the first things I did in Egypt, I didn't take it seriously, really. I studied a lot. I finished a lot of books, making practice 100 hours. In the last 2 exams, really, I didn't take any course. I just studied more and more, because I think that I already have all what I need. Just because I lost the last year, I stopped practicing the medicine. I have some break, so I take some session of clinical before the exam, just for self-confidence, because I am away for practicing for 1 year. But it's only for 1 day, not big days, many days like that. Just I want to see patient and listen again to the murmur, practicing. But in my home, I practicing the last month before exam, or 3 weeks, on my children. on my husband, all the steps of examination, and trying to do it in 3 minutes, because this was a defect in my exam because of nervousness. Nothing. I do the steps, but with finding you and someone looking to you and the stress of the exam and the session by session by session. Really, I like swimming in these sessions. I can't, and I didn't realize it finished till they said it's finished. Okay. In examination, first thing I speak about examination, you should do practicing in your children, anyone, and trying to do it in 3 to 4 minutes. Through maximum 4 minutes, because in exam, in your home, you will not find anything, so you will not thinking. But in exam, you will take finding, and you will take time because of nervousness, someone watching you, and something will maybe delay you. Maybe if you enter the room and the patient will undress like that, it will take from you more minutes. And the half of minute in the examination station will make different for you. You will maybe lose the case because of 30 seconds you need, because maybe the finding in the last thing you will examine. So try to practice examination a lot, the steps, mainly in the weeks before your exam, and try to do timer and make it in 3 to 4 minutes. If you are not practicing medicine, try to take any clinical, or one friend will show you some cases like that. Okay, about the second part, communication is speaking, as a way to speak. Just it is like play game. So try to do with your friend a lot. There is a lot of books you can learn from it. Don't depend on your memory or your evaluation, because we are different and UK have different rules and ethics. So depend on books, because you are still not, even if you are not, if you are perfect, if you are still, till the day of exam, I learn from others. I listen, and yes, I have my point of view, but when I listen to the other, yes, I think he is the right one when he speak about his point of view. So with communication, then not depending on your thinking or what you think about this situation or like that. No, depend on books, depend on someone expert in this. Sessions, listening, just listening of sessions like what Dr. Bassam did. Really, Jazallah khairan. It is very, very beneficial. You will facing a lot of cases of communication. You will deal with it. You know what they asking you and what is their concern. How to, if they trying to make it out of scenario, you will thinking about your scenario still. So practicing for communication, and depending on books and others. Don't depending on like two practicing together. They will giving their point of view or their opinion. No, communication, not your opinion. It is what they need. Okay. The third part, it is the long clinical consultation. This is the big deal, and always this is the one fails the people. Because even if you failed or having like fail in one examination case and giving a borderline or losing a lot of examination marks, no big deal if you are having good in long clinical consultation. This is the very big marks, and if you lost it, you will lose a lot. Usually, long clinical consultation, you will lose by like, if you fail it, you will lose 10 minutes, like the 10 grades, like you will lose marks a lot. So the long clinical consultation is the most focused things you should focus about. For myself, I think I was good in, but I noticed some points like in me when I thinking why I fail the exam. It is really something God decide, but we should learn about mistakes also, and we should know what is defect. Even if you find no defect, just it is hard examiner or someone would need to fill you, so it's no problem with that. The thing is in your hand, you should think about. Out of your hand, don't think. The examiner, it's out of your hand, so it is God deciding. So just thinking about yourself. This is what I did. really, I think in the two feedback, it is silly things they write, but also I take it seriously. Really, I did the examination in front of many experts, and no one like comment on me like that. But they have very bad comment. Really, after the feedback, I have a low mood more than the result itself, because they having very silly comments about yourself, about my performance. So in long clinical consultation, first thing I learn that I be systematic, having past history early, very early, especially in vague complaint like today you complain, having it early, because it will different guide you about the differential diagnosis from the start, so you will not lost in the case. The vague complaint give past history early, and also the constitutional symptoms early in vague complaints, or in any case you are thinking about something you are not reaching system. Like from outside, if you have cough, you have system. If you have bloody urine, you have system. If you have loose motion, you have system. So if you have system for outside, it is easy. But if you have no system, make this point early. It will easy your scenario. Thank you. Second thing, you will. Sorry for the noise. Second thing, to write in the corner what you need to examine before standing up. This is making a very big difference for me. You will be confident when you're standing beside the patient. In Egypt, like they will hide the patient at all. So you will not be like hesitant when you see the patient. Before standing up from ending history, I know what I'll do in the patient. I write it. I'll take, you can have a pause for 1 minute, for 30 seconds, no problem. But you will be more confident when you stand. But what I do, from outside, I already decide. But if I have adding a point, I write in the other corner, in the right corner of my paper, what I need to examine. This helped me too much. Third thing, that please don't miss the positive finding to mention to the exam. Don't say, okay, he saw me when I did this examination. Okay, he will deduct you. I have one hyperthyroidism case. I checking the tremors, the pulse, I checking the thyroid gland and the eye signs, but I missed some points to say that to the examiner. He deduct me for that, and he say like, you saw me that I checked the tremors, just because hyperthyroidism a lot of symptoms, so I missed some symptoms, didn't mention. He deducted me for each symptom I didn't mention. Even I did the examination for it. So very important to like training yourself how to present the finding and the positive finding. Don't be hesitant because it is the first impression with the examiner to present your case. Learn good how to present the case. To long clinical consultation, very good to have time. So please take the most important point I lost in the previous exams, that I have a lot of questions I didn't find time to take. So just one comment about today's scenario. Please like train yourself to be very rapid in the questions that you are not focusing about. There are a lot of questions you are not focused, so train yourself to make it rapidly, like screen rapidly, because it will make you more have time for examination, have time for concerns. So you'll have good impression with the examiners that you're just screening. You are not in the same tone on each question. No, the very important question, yes, you will take it seriously and take time to think about what the patient reply you. But the screening, make it rapidly, because the time very important. Okay. The last thing I'll speak about generally the difference in this exam. I slept good. This is the first exam I sleep before it. I don't know, because I between my family, but I take some medication, truly, but it is not helpful in other days. In other exam, 2 hours or 3 hours, maybe I slept only the night of the exam. This time I slept about 8 hours. It very large difference in my stability, my confidence. I took some medication also before exam, like Indiral, like beta blocker, to make you not, because I have essential tremors. I have, and anyone will in very stress, adrenaline will work. Even if you not wanted it to work, it will work on your heart, on your voice, on your even your hand. So it is, we are doctors, we know. So it is important point really also. Even if you find yourself very confident, they trying to make you hesitant. So if there's something that will help you, it is no problem to try. Try it before your exam by 2 weeks. Try it many times to know how your heart rate if you talk. But it make me different, really. It is the first time also I try. It make me different. I don't know what the difference in this time exactly, but I try to learn from my previous trials. And this time really it is not big deal for me. I didn't make it like challenging day and I waiting for the result and waiting for success. Really this time I'll do my best, whatever the result was. I'll do my best. It is
Yeah,
just
so
a visit to Egypt and
it
to
was
my
no matter
family.
this time. It
France
was like no
also.
matter for you. Sorry,
Yes,
Dr.
yes,
Aisha. Yeah, this is the difference.
yes.
Maybe this is the most important point. You didn't
Me,
take it
yes,
seriously.
I think, yes.
Yeah, and the confidence, of course, was higher than before. This one give
Yes,
you a
yes.
lot of push up to pass this exam. I think so.
Yes, I think this is very
Yeah.
important point. I don't know why I was very confident this time. Maybe because I have no, as you said, whatever what happened, no
Yeah.
problem. And
Yeah.
the other things that I slept good also. This is also important point. And the familiar, this patient, I already graduated from Qasr, so I familiar what they will do, what is the difference. So I think it also have a rule. Before I didn't think that this is a rule. Before I already applying also for UK, no problem with me. But I found in Kenya it is very bad history because I'm very hesitant. I didn't know the people, like they speaking differently, they dealing differently. So really it is important point for me at least. So I advise also to think about the area you are applying in, to be outside of the familiar country for us. And thank you for all. Sorry for the noise again, but
No,
this
no,
is
no.
my
It wasn't.
children
It
part of my
wasn't.
journey. I'll
Yeah.
speak also about. I
They
have
should.
twins. I have
They should
twins.
celebrate also with us. MashaAllah.
Yes, I have
May
twins,
Allah
2
bless them.
years.
MashaAllah. May
And
Allah
all
bless
this
them.
journey with these twins, so
Yeah, it's
I
hard
really
one.
struggle with them. So no one will can find more than this difficulty. So I think all can pass.
Alhamdulillah.
Whatever the circumstances, they can pass.
Yes, it's not the
Yes.
end. I believe it's not the end. You have to believe in yourself, trust yourself. You can do it. Wallah, I
Yes, and
feel.
one advice, really, Dr. Bassam,
Yes.
in the last fail, you know Dr. Mahi. He is
Mm.
very, very good friend,
Yes,
really,
yes.
and from the
Yeah,
great people that
yeah.
I know from your group. He said to me, Dr. Aisha, don't be sad. This is maybe one information you will know again. You will stress on it. Maybe life saving for one patient. May be different in patient life. Even it can reduce suffering of one patient. Just study again. This is all again like hasanat and gratitude in your journey. Just study again for aim of helping people. So it was that. Really, I studying for that only. Thank you for all.
Yeah, thank you, Dr. Aisha, and many congratulations again. You deserve it because you work hard all this journey. It was long, yes, and struggling, as you said, but finally, Alhamdulillah, Allah decided to pass it. Although of the center, although of the all situations, you can do it. Everyone can do it. And I added this sentence in the last video I made for the PACES journey. Go to the center you are familiar with. If you are in your country confident enough to have the exam in your country, do it. Yeah, there is some difficulty, the examiner, one of them. But if you are familiar with the patient, familiar with the center or the hospital, the language itself, so you can do it. Otherwise, some people, they are waiting to have a good center and benign center, even it will come after 3 application, for example. I mentioned already the 3 centers which are having the highest pass mark. So everyone can do it. Don't never ever give up. You can do it after the first, after the second. But I feel sorry really for those who give up and already withdraw and they said, I will not continue this journey. Now, Dr. Mahmoud, and shortly, because Dr. Mahmoud already talked with us a lot, then Dr. Omar will end with him. If anyone else added, Dr. Bakinam or Dr. Shahla, they can talk.
Dr. Shahla here. I think Dr.
Okay,
Best.
okay, Dr. Shahla.
Yes, doctor. Hello, everyone.
Yes, hello.
I have a long history of journey in the basis exam,
Okay, let's
but
congratulate you first. Congratulations for passing the
thank
same
you.
center and the same, I think, Qasr Aini, right?
Yes, القصر العيني.
Yes, yes. Okay. Tell us about your experience now. You can start.
Yes, my last experience was the best experience, and Alhamdulillah, every effort, Allah will be accumulate every effort, and finally will give you the best map and the best mark. So in the last exam, just I was already start in the PACES journey from the 1 year, and my first experience in the Alexandria Center was bad, and I try second times also in the Alexandria Center also was bad, and I decided finally to change the center and send a lot of the emails to the Royal College to try get a seat in the Cairo, and finally give me the seat in the Cairo. So just the most important thing, practice, daily practice, because by the practice you will become fluent in the exam, even if you complain from the some mental block. Your hand will be do everything, and your tongue will be give every words that already recorded in your brain. So really the Qasr Al-Aini Center was the best center in the surrogate. The surrogate was well trained, and the examiner was fair, and the case also was not easy, but a case typical like the medicine book. And the two communications case, one communication was functional disorder, and everything is okay. The patient complain from the abdominal pain and the headache and the generalized fatigue for the long time, and finally the consultant do investigations and CT, and everything was normal. So I managed the functional case, and the surrogate was have anxiety and try to cut my words, but everything is okay finally. The another communication station was polymyalgia rheumatica, and the most important thing here, from the outside, the scenario was talk about the polymyalgia rheumatica. The patient complained from joint pain, from stiffness, and everything do, and the consultant decided the patient has polymyalgia rheumatica. Go to the patient, talk about the diagnosis and the prognosis and the association only. When I enter the stations, I bring this bad news and talk about the polymyalgia rheumatica and the prognosis, and tell the patient, if you complain from any headache or eye pain, please came to the clinic. And in every minute I ask the surrogate, do you have any concern? The patient say no. The surrogate say no. Do you have any concern? The surrogate say no. When I reach the management plan, by luck, I said this consultant may give you medicine called steroid. So this is the hidden concern. So the patient give me gush from questions. You mean you will give me steroid, and my friend receives this medicine and have thinning of the bone. Steroid may cause for me high blood pressure and high blood glucose. What happened if I not receive the steroid? Can I stop the steroid suddenly? A lot of questions only about the steroid, although not mentioned outside. This is the hidden concern. And my colleague that not mentioned about the steroid lost this station. The long clinical consultation, the most important thing in this station, time management. And the most important thing in LCC station, I advise all colleagues, examination, the most important thing. You need to complete the examination and get all the finding. If you not complete the examination and get all the finding, you will lose this station, although you may take complete history. So I advise all my colleagues, you observe your time. When you reach to 7 minutes, you need to stand and go to the patient and start examination. And during that, you may continue to ask the questions that remaining, but you need to start examination early to become relaxed. Because if you start examination late, the time may become short, and you put under the stress, and the examiner will not give you the full mark. يعني we observe in a lot of the feedback, the examiner comment about the candidate take long time in the history, but no examiner comment about the patient take short time in the candidate take short time in the history. So the examination, the most important thing in the LCC and the finding. This is from my experience. And I advise all my colleagues give 7 minutes for the history and the remaining time for the examination to become able to get the finding. Because if you not get the finding, you will lose this station, even one by one finding or two finding. So my first LCC was from the outside hand pain. When I go to the surrogate, hand pain in the hand and in the feet. What else? Any another pain? No. From the history, the pain was inflammatory, and I take the rheumatological review, and there is a stiffness and there is tightness in the skin. After that, I say I need to see my patient, typical scleroderma. And I also ask about the Raynaud phenomena and complete my history. And the patient also complain from the dysphagia and renal problem. So my finding was scleroderma, typical. Also in the examination, start by examination of the hand, and I also examine the feet because the patient have hand and feet pain at the same time, and start examination from the eye to the bottom. Examine the chest for any crackles, examine the heart for any pulmonary hypertension, mouth for any soreness, and proximal myopathy, and the eye for any redness, and the abdomen, everything done. After that, the surrogate asks the most frequent questions. What could be the cause? It is curable. That children can get this disease from my brothers, and the already questions. So the examiner also asked me the already questions. What's your diagnosis, the differential diagnosis, the management plan, and focus on the antibody for the mixed connective tissue disease, and ask me, did you rule out the mixed connective tissue from the history? I said yes. There is no soreness in the mouth, there is no rash, and focus on the rash when exposed to the sun and the muscle pain. And after that, said me, if this patient came with high blood pressure, what's the medicine that will give? I said ACE inhibitor, and you need to rule out anything. Yes, I need to rule out bilateral renal artery stenosis. And also I asked me, this patient need admission or no? I said no, because vitally stable, but I will do investigation to evaluate the condition. After that, the another stations was dizziness, but from the outside, not written dizziness. Right, the patient fall in the toilet 2 times. When I go inside, I found my patient have dizziness, visceral hypotension, And if I found Bushra hypotension, the first question, any past medical history? Yes, because the most frequent case I face in the exam, autonomic neuropathy. So said, and atrial fibrillation. Said for me, yes, my mother have diabetes and hypertension. I asked the 13 questions for the diabetes and also for the hypertension and do review. And I said, give me your please at a list, medicine list. So the list that I received was contain dipamide and dapagliflozin and metformin and amlor and also aspirin. And I said, any recent added medicine or a change in the dose? Yes, the heart doctor added medication, but I not remember which one. So I assume that's medication in dipamide, and also the patient from the history has polyuria and UTI, and I am focused on the DAPA. Examination, I am focused on the pulse because the most frequent cause also atrial fibrillation, and also auscultate for the carotid, and ask for the fundus, and auscultate for the aorta, and do superficial examination of the abdomen, and do upper and lower in the hand and in the feet, one tone, one power, one reflex, and sensation, and ask for the bedside blood glucose, and also for the urine dipstick, and also ask for the blood pressure sitting or standing. So my first differential diagnosis postural hypotension because of the indipamide. I advise the patient to stop indipamide and DAPA because of the urinary tract infection, and I will involve heart doctor to replace with another suitable one. So ask me the first differential diagnosis and another. I said another autonomic neuropathy, but there is no symptoms. There is no any signs on examination. Could be due to valvular heart disease, no aortic stenosis. Could be due to atrial fibrillation, and another arrhythmia. Could be due to TIA. Could be due to hypoglycemia. Could be due to bleeding. Could be due to dehydration. Ask me for the investigations, and after that, for everything was okay. For the clinical stations, chest was COPD بلدي and with the crackles, but the crackles changed by the cough. So I not said idiopathic pulmonary fibrosis or pulmonary fibrosis because the examiner asked me, this crackles changed by the cough or no? I said yes, changed by the cough. So I assume infection more. Oh yes, this was the case. COPD with community acquired pneumonia. And investigations and management and differential diagnosis. The cardiovascular was metallic valve replacement with atrial fibrillation. And my colleague that missed this atrial fibrillation was lose the case. The most important thing, give time for the pulse. Please, in every station, give the time for the pulse. The pulse is the most important thing. And ask me for the differential and the causes and the management of atrial fibrillation and anticoagulant and atrial fibrillation and metallic valve replacement, the target, and if the patient came with upper GIT bleeding, and if the patient came with hemorrhagic stroke, and what you need to do, and blah, 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 blah. And my neurological examination was Parkinson. Upper limb examination, I found the patient Parkinson. I do a neurological examination for the upper limb, and I ask for another. I need to do glabellar, blepharospasm, a mini mental status score. I need to do a supranuclear gaze for palsy. I need to see blood pressure sitting or standing, and I need to do stereognosis. And the examiner said no need, no need, no need. After that, ask me for the differential diagnosis, ask me about the Parkinson Plus, and ask me for the side effect of L-DOPA. Focus on the side effect of L-DOPA. And after that, the abdomen. The patient was have hepatomegaly and splenectomy and not thalassemic feature, but have a prominent maxilla. The maxilla was prominent and has jaundice. So I do the examination, and after that I say the patient have kaza, 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 may due to hemolytic anemia vs chronic liver disease. The examiner satisfied with this answer and ask me about the some investigations for the hemolytic anemia and some investigation for the liver and ask me about the cause of the hepatitis or the liver pain in the hemolytic anemia, and ask me for the investigations and the management. This is all. Yeah. The most important thing in the basis exam, you need to become relaxed and believe everything will be okay. And you need become the most important thing the examiner focus on it, the welfare in every step, and gentle dealing with the patient. This is all experience in the Al Qasr Al Ain exam, the best center. Really, the fair examiner and the good organizations and the very good surrogate.
Yeah, thank you, Dr. Shahla. It's the best center in Egypt.
Yes.
So yeah, you can say in Egypt only, not on overseas. But it's yeah. Again, it's the Alexandria, which is a new center, toxic one, bad experience from a lot of candidates because they don't have the experience of Al Qasalaini. Just I think last or 3 days before started to publish as examiner center or examination center. While the Qasalain, I think since long time, even since the old style of basis, the old format. So no difference or no comparison between both. Major difference and no comparison between Alexandria or Al-Qasalaini in Cairo. Ain Shams, I heard also it's a new center, but it's a challenging one. No one write it. I don't know if it's different or separate.
bad center, Dr.
Yeah,
Basim.
yeah.
Ain Shams,
Bad.
no one success in Ain Shams last diet, I think.
Dr. Mahmoud, any new center
Yes,
will be bad. They don't have
yes,
well-trained surrogate. They don't have local examiner who are familiar with the basis exam. So they should be
yes.
or they must be bad. The same, what I guess, Jeddah Center, which is new appeared, I think so it will be the same idea because they don't have the volunteer as a surrogate to do basis because they don't have this experience in Saudi Arabia. Maybe it will be different and good, but
Yes, but I think
my
Dr. Basim, the examiner in Jeddah will be from Qasr Al Aini. All the examiner
oh
from the
my
Qasr Al
God.
Aini. Dr. Ahmed and yes, الشلة بقى.
Oh, but why from not from Saudi Arabia?
I
They
don't know,
have.
but many my colleague in Jeddah did some mock in the same center.
Mm,
So
okay.
they told me that the examiner from Cairo, the same examiner, the same.
Yeah. What I believe, Dr. Mahmoud, any new center will be difficult to pass.
But
The old center who knows.
not be
Uh,
difficult than Alex, Dr. Basim.
no, Alexander new center. It's a new center.
You know,
So the
Dr.
same.
Basim, in Alex only three examiner only. Three examiner only. Very malignant. Even you finish the case very well and told all the information in the case, you will also lose the case. I don't know why.
Yeah, I remember my exam in Alexandria. The one who gave me good marks and full marks in the long clinical consultation was the external examiner. I didn't face local examiner in the long clinical consultation. That's why I got full mark in both scenarios. Both of them was British and living in England. They came, although one of them looked Egyptian, but he was British. I asked, he was British.
Yes. Yes, also when I take the exam in the Alexandria, the station that composed from the British examiner, I take in full mark. But
Exactly.
station and the Egyptian from the Alexandria, especially, I take 0, 2, 3 mark.
Really, yes, they are very malignant. I don't know why they are thinking the exam from their point of view, not as basis point of view. Forget about Alexandria. No one apply, please. No one apply in Alexandria.
No,
It's a
I
big
encourage
trauma.
everyone. No, I encourage everyone to put a formal complaint because the royal colleges will
No,
feel for its
no
money.
matter.
I
No
sent
matter.
many complaint,
No
Dr.
matter. No
Sent
matter.
many
No matter.
Not
complaint.
Yes.
singular, not singular, not singular, not
Dr.
singular
No
Bazin,
matter,
complaint.
Dr. Omar. Yes. Yes, Dr. Henry.
Dr. Bazin,
Yes.
hello.
Yes, we can hear you. Yes, Dr. Omar. Dr. Henry, yes.
Actually, I just applied for this diet again, and I put Alexandria.
No,
Oh my
don't go,
God.
doctor.
No.
Don't go, Dr. Omika. Don't go.
I just did that today because I just saw it. There's a space, so I just applied, and I put Alexandria.
Yes,
Oh
no,
my
Yes.
no.
God. No.
Believe
I'm,
me,
Better to
Dr.
in fact,
stay,
I'm just like I wasn't
Dr.
aware
Hene.
that it's this malignant.
It's better to stay in UK waiting in waiting list rather than going to Alexandria paying more money with no benefit. This is what I believe. And Dr. Ahmed added here one comment. It's yeah, I believe in this. Local examiner in Alexandria are not MRCB certified. Yes, they are only.
Oh my God.
I
Trained.
think.
Trained.
No, not trained.
MD,
They are just
MD.
MD. Yeah, MD
Hmm.
from Alexandria. So they have their
Oh,
own technique how to examine, and they want you to do it in their preference, which is not basis wise. I remember.
yes, doctor. Yes,
I
Dr. Basim.
remember.
In the
Yeah,
abdomen station, I lost. In the abdomen station, he gave me 4, only 4. Why? Because I don't need
you start.
the patient feet during examination.
Hmm.
So he gave me unsatisfactory in physical examination. He gave me unsatisfactory in physical science. How come?
Yes,
How come that?
yes. Not only that. If you start, I usually my habit to start from the end of the bed, as I always advise. Whenever you are standing at the end of the bed, start looking at the legs. No one from the all UK examiners commented that I started from the legs. No one in on all my experience. Alexandria doctor, he wrote, he examined the legs before he examined the. What the matter if I examine the legs? Because I was there. What the problem from?
Mm.
So I think they are malignant. For me, they are sick, and they cannot pass anyone. So Dr. Henry, don't go at all. Wait in the UK centers. In the waiting list, it's okay, better than going there having the jumble. Okay.
Oh, thank you.
Thank you, Dr. Shahla. Yeah, thank you, Dr. Hina. Thank you, Dr. Shahla, for your sharing your experience.
Welcome,
Uh,
doctor.
yeah, thank you. Thank you so much. Now, Dr. Omar or Dr. Mahmoud in 5 minutes.
Yes. Okay. Okay, Dr. Basim. I can wait until tomorrow, Dr. Basim. No
Y-
problem from me.
Dr. Mahmoud, mashallah, you and Dr. Omar with us in every station, or every session, sorry.
This is Dr. Basim.
So you are sharing.
I want only
Okay.
to say one important thing.
Yes, please go ahead.
Only one. I want to give great thankful to Dr. Basim for this meeting. That is the most important thing I wanted to tell in this meeting.
Thank you, Dr. Mahmoud.
So thank you, Dr. Basim. Yeah, really, really thank you for your effort. You were with me every step. You always give me the confidence, really. Very, very, very thanks, Dr. Basim.
Thank you, Dr.
So
Mahmoud.
my
Continue.
yes, my experience in Hari. This is the third time I go to MRCP basis. First time was in Qasr Aini. Before the first diet, I study and I read many books, OSCT and Oxford and Watson's, many books, and really, really, it is useless in the basis. Basis only need practice, then practice, then practice. Okay, and to be structured. First diet, I think I was having many information in my mind. So I went to the first diet without knowing the skills. So I lost the clinical judgment skill and also clinical communication skill, and also I think yes, identify physical science skill. I think the problem was from me, not from the examiner. First time was in Qasr Ain, Cairo. So I didn't ask about any family history, any what is your job like that. So I lost the exam, although I know all the cases in the exam, short clinical and communication and consultation. I know all the patient diagnosis, but I lost due to the skills. So it is most important to know about the skills before going to MRCB basis. Okay, that is the first thing. Second experience was from Alexandria, and really it was very bad experience, really very bad experience. I was doing everything in this diet, although I failed. I don't know why. I lost only 2 stations. One clinical consultation because of one local examiner, and his was very bad. And the second station was abdominal station. The third experience was in Qasr Aini Hospital. Really, it was a very good experience and very good center. I think why is this good center? Because all the examiner in this day was British, not Egyptian. The
That's
first,
why.
yes, the first examiner,
It
Dr.
was
Bassem,
exceptional day. It's not usually
I
passing
don't
all
know.
candidates. Yeah,
Yes, I
I
don't
think
know why.
also.
Yes, the first examiner was British. In any station, the first examiner was British, and the Egyptian
Thanks, guys.
beside him. So I wanted only to share one station. It is yes, long clinical consultation station. That's why we have to keep practice and to keep the structure in your mind. This consultation was from outside. It was forgetfulness. Okay, so I put in I write in my paper. It may be Alzheimer, maybe like Lewy body dementia, maybe Parkinsonism, maybe
TGA.
TGA. Yes, I put all of this. When I enter the station, so I didn't tell the surrogate, your father have memory change. No, I tell the examiner what brought you to the hospital today. Your father today, he told me that yes, doctor, he has confusion. So I told him he came because of confusion or anything in his memory. He told me, no, doctor, he has confusion only. His memory is good. I don't know how. And I told him again just to confirm he has any memory change. He told me, no, doctor, he has confusion. So when I start in station with basic OCD, onset, course, duration, very basic. It is very good. When it start, it is increasing, decreasing. For how long? Any time at the night or at the morning. Uh, so it started only since one month. Okay, 1 month. This confusion. So I till now my mind was changing. The pathway changed from memory change to confusion. So I in my mind the confusion causes in my study is only 3. Maybe infection, maybe electrolyte imbalance, maybe neurological. So I told him any past medical history. He tell me yes, doctor, he has cancer kidney. When it was diagnosed, he told me since 6 months, and he take chemotherapy. When was the last session? He told me since one month. So I told him the confusion started after this session. He told me yes, doctor. After the session, he became confused. Okay, that's very good. Any change in the water work? He tell me no, doctor. Water work is normal. Okay, any change in the stool? Yes, tell me, doctor. Yes, he has constipation. So I go to in the way of hypercalcemia. Okay, any heartburn? He told me, yes, doctor, he has heartburn. So once I reached the diagnosis of hypocalcemia, in my practice, always I examine, like Dr. Shahala said, I examine, and during examination, I ask some question like the social, smoke and past history and drug history and job and the smoking and the impact, all of this in the examination. So I start examination at 6 minutes. The examination was very strange. I don't know why, because I started from neurological examination and going to I tell the patient about in the examination. I remember that I should ask about oriented to place and person and the time. So I ask the surrogate when I examine, does he know where we are? Does he know me? What I am? Does he know what is the time now? So I remember it during examination.
I remember this complaint you did it to Dr. Ala, the confusion.
Yes,
Many times.
I practice confusion, Dr. Bassem, many
Yes.
times with
Yeah.
Dr. Ala, with Dr.
Yes.
Omar. many times.
Yeah, in my
So
session,
I
yes.
take this station like practice, only
Revision.
yes,
Yes.
revision really. And then I examine. I go to the heart, no change, and examine the back, no change, and examine all neuro examination. Even I examine the lower limb for hyperreflexia and Babinski, and patient have upgoing plantar. I don't know why till now. And then I want to check the reflexes. So the patient was having tight closes in his leg. So I asked the examiner, I want to check the reflex. He tell me, okay, go on. I tried to lift the closes, but the patient can't. So I didn't examine the reflex on the close. So I forget this reflex, no problem. And going to the abdomen, patient wasn't, and going to the abdomen and examine the liver, patient has hepatomegaly and splenomegaly, and also I check the kidney. Patient have renal cell carcinoma, so I check the kidney. And then I go to the concern what my father have. I told him that Dr. Basim learned us. Your father have a few possibilities. One of them may be some salts has a disturbance in his body, so we have to admit him. And the examiner tell me, does this patient need admission? I told him yes, he need admission. He has hypercalcemia, so we have to admit him. And the candidate told me, okay, doctor, what is the other possibility? I told him maybe spread of cancer into the brain. So we have to exclude it also. And then during examination, the examiner told me first thing, okay, what do you think about this patient? Does he have any memory change or confusion? No, I told him no, he has confusion, not any forgetfulness. No, patient doesn't have any memory change. And then he asked me about, okay, what is your differential diagnosis? I told him maybe hypercalcemia. Tell me what else? I told him maybe myths from cancer to the brain. He told me, and then he told me what else? Maybe electrolyte imbalance, hyponatremia, and told me yes, what else? I told him less likely to be tumor lysis syndrome, because the confusion started since 1 month after chemotherapy, but it is likely because patient have hypercalcemia, and in tumor lysis maybe it will be hypocalcemia. And they told me what else? I told them maybe increased antireotic hormone, SIADA, but it is likely in this patient. And then he told me what will you do for this patient? I told him first I will admit my patient and give him fluid, and then I will do some investigation like CBC looking for anemia, and also I will do ECG and inflammatory markers. In this station, one friend doesn't examine the patient because he go into the forgetfulness, memory change, and he asked about everything about Parkinsonism and Lewy dementia and Alzheimer. He go into the forgetfulness. Patient doesn't have any forgetfulness. I don't know why Dr. Basim they write from outside forgetfulness and inside it is confusion. I don't know why. But in this station,
Let's take a home message from this complaint. Whenever you have complaint, ask by yourself what the nature of this. What do
yes,
you mean
Dr.
by
Basim.
this? Yeah,
Yes.
because usually they have another complaint or associated complaint or a different meaning which you are misunderstanding, and you will go through a pathway which is wrong. Then at the end you will find another complaint.
Yes,
Continue.
my colleague Dr. Basim didn't examine the patient because he went into the pathway of memory change and TGA and stroke and like that, and he didn't know the diagnosis, and so he didn't examine the patient. Okay, the first case, although it is very simple case, it's a case of hyperthyroidism. From outside, it was lose weight. So I put from outside in my mind, lose weight. I will ask about the appetite and the diet and the exercise. And going into the pathway, if it is lose weight with loss of appetite or preserved appetite. That is in my mind. So I went into the station. Just it took me, from me, I think, 2 minutes to know the diagnosis of the patient. Although the patient was hidden, I didn't see the patient, but I asked, lose weight, and then what about appetite? He preserved appetite. Okay, so I put in my mind maybe cytotoxicosis, pheochromocytoma, and malabsorption syndrome. So I asked after appetite preserved. So I asked about any neck swelling. He tell me no, yes. So it is cytotoxicosis. And then I went into the pathway of cytotoxicosis to know what is the cause of cytotoxicosis, and I asked already about the family history. And the family history, patient has diabetes, mother has diabetes, and ask about lose stools. Diarrhea, about diarrhea, yes, it is diarrhea. So I should ask about what is the nature of this diarrhea. This diarrhea due to because this is the question examiner, and I asked already in the history. Okay, what is the diarrhea? He tell me yes, doctor, this is diarrhea. Awake you from sleep? No. So it is not celiac. It is due to cytotoxicosis. It is bile bulky offensive? No, doctor. It is loose. So it is diarrhea of loose due to cytotoxicosis, and it's one of the question of the examiner. I think the examiner was very kind with me because I examined this case very well. Really, I even examined the lymph node, inguinal and axial, axillary, and cervical, and examine full thyroid. Even I listened to the bilwi. This patient was having bilwi, but I forget the pretibial myxedema. So be confident with the examiner. It is the most important thing. The examiner tell me, okay, you listen. He said to me like that. I see you putting the stethoscope in the neck. What do you find in the neck? I said him, I think I told him like that. Me be bilwi or me be increased vascularity. The examiner tell me, okay, what do you think? It is bilwi or not? I tell him no. It is not bilwi, maybe increased vascularity. He tell me yes. Okay, and he told me okay, yes. And then he asked about what about the diarrhea? What is the cause of diarrhea? I told him I was putting in my mind maybe due to celiac, but it is not malabsorptive, so most likely to be cytotoxicosis. And the examiner told me, did you examine the leg? I told him no, but I should examine the leg because maybe pretibial myxedema. I told him that maybe it's one of the features of Graves' disease. He told me yes, okay, doctor. And he went with me with the investigation of cytotoxicosis. So be confident. He asked me about what is the investigation. I told him all the investigation. I told him autoimmune anti thyroid-stimulating hormone antibody. He told me, "Are you sure that this the auto antibody of Graves?" I told him yes. He told me again, "Doctor, are you sure?" I told him yes, doctor. I am sure it is the auto antibody. So be confident. If the examiner see you confident and doing the case smoothly, he will give you the full mark. Really. In another station, it's the abdominal station. This station take from me with the examiner 2 minutes. I examine the abdomen, and then the examiner he tell me what is your finding. I told him the patient have splenomegaly, 5 fingers below the costal margin. He told me directly, what is your diagnosis? I told him according to our region it may be bilharziasis. He didn't told me what other diagnosis. Once I told him bilharziasis, the examiner was very satisfactory with that, and he told me what is the investigation and treatment, and about splenomegaly. I told him that antibiotic and like that, and treatment. I will told him that if he has any pain, I will going to splenectomy. And the question are finished. I think 2 minutes, and to complete his question, he tell me what is okay. Do you know the cycle of bilharziasis in the body? I told him frequently, honestly. No, doctor, I don't know, but I know that according to our region, maybe schistosoma mansoni, breaking the skin and going to the portal vein, causing portal hypertension. That I know. And he gave me the full mark because I am honest with him. So be confident, be honest with the examiner and with the patient. If you didn't examine anything, tell the examiner, yes, I didn't examine, but I should examine that. Don't give up with the examiner. If the examiner see you give up يعني رميت الفوطة خلاص وكده, he will squeeze you and they like that. So be confident. If you don't know, tell I don't know. It is very very easy. Um, and thank you, Dr. Basim.
Okay, thank you, Dr. Mahmoud. Again, the take-home message: whenever you are confident, the examiner will give you the mark, even if you mention something wrong. Sometimes it can, you can mask the examiner that I am confident and this information, I know it, I am very confident about it. He will not focus on this information. Other point and the other take-home message: give the differential sense or the sensible differential to your center or to your country accordingly. For example, bilharziasis, as Dr. Mahmoud mentioned, for chronic liver disease and portal hypertension. What about hepatitis? If we are in UK, which hepatitis we will give? We'll give
Hepatitis A and E.
B.
C
No,
and
no,
B?
C
B.
in Egypt.
In Egypt.
No, C, it's common here in IV drug users. It's very common.
B. C in
C,
Egypt.
yeah, C, B is not common here because of the vaccination. So C, if someone will acquire infection, it will be because of C. In the UK, it is always C. Because all of mostly they are vaccinated against hepatitis B.
Yeah, there is vaccine for healthcare worker. But what I want to say, the blood and the blood-borne infection will be hepatitis B, not hepatitis C.
Yes, but the trend I'm talking about right now for someone who is giving the exam in this era, he will prioritize C before B if he does have any blood
Yeah.
if he does have any risky behavior,
Yes,
because
exactly.
likely they will from early 1990s they
Yes.
are giving the vaccine obligatory. In Saudi
Yeah,
Arabia,
yeah,
it was from 1994
yeah.
because I was born in Saudi Arabia and I didn't receive the hepatitis B vaccine because I was born in 1993. So this is the in Egypt I don't think it's obligatory to have unless you are
No, nothing. No one
yeah
will give anything in Egypt.
yeah
So,
so
but
this
hepatitis
is the
C is the
problem.
commonest in Egypt. If you want to
Yeah.
mention hepatitis in Egypt, start by hepatitis C. And it was one of the case of my cases, and I got full mark because I speak about hepatitis C prior to mention the other causes. He asked me what the virus could be here. I said hepatitis C. I did mention B. Then I speak about other differential, and I got full mark. What I want to say, try to give the sensible differential related to the center and the country you are in. Okay. I think, yeah, thank you, Dr. Mahmoud, for sharing the experience. I don't know if Dr. Omar can summarize or we can do it in another session, in detailed one.
This is It's just a very quick
Okay.
thank you.
Okay. Yeah.
Thanks to Allah
Okay.
subhanahu wa ta'ala, and then thanks to the people of this group, especially Dr. Basim. It's just an expression of gratitude, and we hope that we will be able to be as resilient as you in continuing sharing the knowledge. This is the only thing that it's the only summary is the resilience from other candidates and but after Allah subhanahu wa ta'ala is from Dr. Basim. To be honest, the difficulty that I was facing here that there was no one to practice with And one colleague has advised me to join this group. He was passed. He had also a very difficult journey here. He kept facing very rare cases in his exam, but thankfully he's passed now. But he also benefited. He likes to stay in the shadow. He might have not encouraged himself to practice publicly, but he is the one who asked me to join this group. So I hope that we are all people who have passed to continue supporting the others. Um, uh, I know that the schedules of everyone might get busier, but at least to keep revising for yourself, because keeping the revision or to be on top of the refreshing your information is important. I think I won't be speaking more than this because it's now almost suhoor time in for every country. I still It's still early here, but again, thank you, Dr. Bass.
Okay, thank you, Dr. Omar. We'll reserve your cases in the long,
Yeah,
especially for Dr. Ahmed, in another day. He will be lucky to have this case because he has his exam in UK. It might be repeated. Mostly they
what,
are
what,
repeating the case. So,
what is his exam? Where
uh,
was his exam?
which
Middlesex,
center?
Which center? I'm sorry, I didn't catch it.
Middlesex Hospital,
Is it in the south?
near for London,
Near
near
for
the
London.
airport,
Okay, okay. Which college?
Imperial,
But the
London,
College of Entry. No, the College of Entry. Is it London?
London, yes.
Okay, okay. Good luck, and uh, you can send me a message on the WhatsApp. I will also be able, inshallah, to guide you.
Yes.
Uh,
Share with him some of the recalls, especially this hospital. Let's help him.
yeah,
He's our candidate nowadays.
Thank you,
Hopefully,
Dr.
yeah.
yeah, soon exam, right? I think you told
When
me.
is your exam?
Middle March.
Yeah,
So
so
after this session, are you
matter.
free, Ahmed?
Yes.
Okay,
Okay. Mhm.
just drop me a message. I will let's spare Dr. Basim head.
Thanks and congratulations for all.
Yeah, soon, inshallah, Dr. Ahmed will congratulate you. You will pass the exam, hopefully, with good experience and with a good practice. You will gain a lot of confidence with us, hopefully, as well. The structured and organized way, I hope also I can help, and all of us in the group will help you in this.
Thank you, Doctor.
And hopefully, inshallah, he will help you to pass this exam. So,
Inshallah.
any question from anyone?
Thanks, Dr.
It's
Basim.
just
Thank
a general advice. If someone is giving the exam in the UK, you do have basis teams in your hospitals. Contact them uh, 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 beforehand. Join the basis practice in the hospital. There are usually some consultants who are enthusiastic about practice, about finding cases. Shadow them. Do it whilst you are tired, to push your limits. I'm talking in the UK. This is usually how you will find most of the cases with signs.
Okay, it's good advice. Thank you, Dr. Omar. Thank you, Dr. Mahmoud, for organizing this meeting today with Dr. Aisha, uh, Dr. Who was the second? Suppose Dr. Bakinam, Dr. Shahla also, Dr. Omar, Dr. Mahmoud. Again, many congratulations. Your success means our success. So
It's your success, Dr. Basim.
really,
Yes, it is your
wallahi,
success, Dr.
Thank
I
Basim.
you
It's
very
okay.
much.
you
I
don't
will
know how
never
much.
forget the
Yeah,
help
Dr.
here.
Aisha as well. Yeah, Dr. Aisha, one was who started the journey, or I started the journey with her. Maybe 2 years back, right?
Yes, the first time I make practice because Dr.
Yeah.
Basim here in the group, and I'm very shy about what I did. But he's the first one encouraged me to apply for exam. I still hesitant about applying. Then I take the step after some days of practice with him in this group. And this is really the first step in my basis. And thanks for God that
Alhamdulillah.
I
Yeah.
know you all. Really, it is very great gift, and I hope I'll
Yes.
remember you always in my prayer, and always
Thank you.
I hope I'll be in contact with you always, inshallah.
Yes, at
let's
any
pray
time, everyone are welcome.
for Dr. Alaa
Yeah.
to pass,
Yeah.
inshallah,
Yeah, hopefully, inshallah, he will
just to
pass.
remember him. Yeah.
Ya
Inshallah.
Rabb, inshallah.
Ameen, inshallah. Okay, thank you everyone for the attendance today. I hope this session will help other candidates. It had a lot of experiences, a lot of advice. And again, anyone has any comment, feel free to comment, to message me, to share with me this group for all of you, not for me. Even the name of the group, Paces for All, not for me or for anyone else. Okay, thank you for the attendance today. Thank you, everyone. See you tomorrow, inshallah, the communication day. Good luck and good night. Assalamu alaikum wa rahmatullahi wa barakatuh.
Alaykum salam.
Wa alaikum assalam.